Welcome, everyone. Thank you for joining us for our April Faculty Development Panel, From Classroom to Clinic, Bridging the Gap with Health Sciences Learners. I'm Dr. Jessica Seaman, Assistant Dean for Faculty Development in Creighton School of Medicine. I have just a few housekeeping items before we introduce our panelists. This session is being recorded and you will have access for future reference. We invite you to submit any questions in the chat to everyone, or you can just send them to me, and we will get to as many questions by the end of the session. We do ask that you remain muted with video off unless asking a live question to assist with the recording. Also, this session is eligible for continuing education credit, and you will receive the website and the activity code at the end of the session. There is a short survey associated with the continuing education, and we thank you in advance for providing feedback as we continue to build robust programming for our health sciences faculty and staff here at Creighton. Now to our panelists. We have Dr. Sonal Harder, Assistant Professor in Creighton School of Medicine. We have Cheryl Houghton Hamilton, Simulation Education Director with Creighton School of Medicine. And we have fourth-year medical student, Denzel Matthew, and third-year medical student, Matthew Sacco. So I'll turn the time over to Dr. Harder to get things going.
Good afternoon, everybody, and thank you so much for joining our session. This topic took birth when Cheryl and I and some of our clinical skills team members were talking about how do we see our students in the community. We have the privilege of teaching our M1 students and our M3 and M4 students. And for Cheryl and I, this is our first year teaching actually the M1 students. And now we get to see these students grow longitudinally. So from first year all the way to fourth year, and hopefully also see them as residents. And one of the questions that came into our discussion based on student feedback was the moral dilemma that the students faced when they got into clinical scene. So let's say they go through M1 and M2 year, and they learn how to do medicine, how to examine cardiac exam, or how to do a neuro exam. And then they go into actual medicine, and they do see certain behaviors or certain ways of doing the same process that they feel conflicted about. And they feel like there is a moral dilemma. Well, wait, we were taught this way, but that's not what we necessarily see. Whether it's clinical medicine or whether it's behaviors or whether it's professionalism or whether it's the holistic approach of medicine, a lot of students actually experience moral dilemmas. And I can tell you as a clinical outpatient internist who has done clinical medicine for the past 14 years of my career, alongside academia, it is a very difficult balance. It is a very challenging process to teach, to see patients, to be a good role model, and be very, very productive to your hospital. So that's the premise of what we are talking about. And I will actually introduce Cheryl, who introduced the concept of conformity to us in that discussion. And her knowledge of that and how this topic sort of came into our discussion. So Cheryl, would you mind telling everybody what your thoughts are about this topic?
So I think this year it was highlighted for me, as this is the first year that we're working with M1s. So prior to this, we got the third and the fourth years, and we had no idea of what happened in the first and second year. So now that I am working with M1s, I know what we're taught. We spend so much time using evidence-based knowledge to teach them how to do things the right way. How, as you said before, how to listen to the heart, how to examine the lung. And we talk about, the patient you have to do these things directly skin to skin and make sure that you are actually, disrobing the patient to be able to visualize and see things on the patient. They, then I would see the third years particularly come back to do STEM within their clerkships. And as we're observing, and I have a checklist of things that I have to check off that they're doing the right way. Certain things, like again, doing the exam under the gown or positioning the patient in a certain way or assisting, I don't see any of that happening. So after the sim, we go in and we debrief. And I said, I noticed that you listen to the patient's heart over the gown. Tell me about that. And the response consistently has been, well, that's what I see in practice. This is what I'm seeing. And so we have the conversation about what are your thoughts on that? Well, that's what everybody's doing, and I want to fit in. I don't want to rock the boat. I want to be part of this group, and I want to stay in good favor, in good stands with the preceptors or facilitators that are grading me or watching me or making decisions about what I'm doing. So that's where it started. And I'm like, I don't understand. We're spending so much time, 2 years with these students, teaching them this is the right way to do something. And they hit a wall when they go to practice. And how are they supposed to navigate that? What are they supposed to do? And how are we helping them to manage what they've done in academia for 2 years? And now, how are we bridging that? How are we helping them? And the silence is a conformity in that they go along with everything. They're afraid to rock the boat. And they really don't have anywhere to go to have that conversation. And the time constraints that are involved in maybe meeting with a facilitator or a preceptor and having that conversation. Tell me, I don't understand. I'm really distressed sometimes. Is that moral, ethical thing that comes to play? Is what is the right thing? What should I be doing? So that's where that started with me. I mean, it's at the end of the day, we're looking at what is safe for our patients, and that's our foundational for everyone. So if we have conflicting ideas of how to do the right things for our patient, how is a student at every level? I see it in nursing also, where the student comes back to me and says, Cheryl, you've taught me this, you've taught me that. But when I go out there, they say, oh, you don't have to do that. Mm-hmm. So that's left to the students then to have to navigate this and move forward.
And I think, Cheryl, when you had brought up this term, conformity, I actually had to look it up to clarify my own definition about what that meant, because I always had a negative connotation to that term. And so one of the things that I found out was there's a difference in conformity and obedience. Conformity is basically you adjust to the environment. So like you mentioned, students are on a team and they just, although they see something that they are not taught that way, they just go along with the flow because they are trying to conform to the environment. Obedience is basically sticking to the rules and policies, regardless of what is happening in the environment. And I can tell you firsthand that as a teaching attending, I have had to conform many times with changing times, with changing environment. And I actually see that as not such a negative thing if done right. And so I want to move it to Matthew and Denzel and kind of shed light from your perspective as students on this topic a little bit. So Matthew, do you want to go first?
Sure, yeah, I can talk a little bit about, I guess, just that conformity that has kind of been brought up, and moving from being in the classroom and being in an academic setting and being taught how to do a really thorough physical exam, and then you move into the clinical world, and while you want to really make sure that you're getting all of your objective pieces of your exam done properly and making sure that you're collecting all of your information, sometimes it's difficult, specifically with some of our patients who are in a hospital bed and can't really get up or move around too much. It's difficult to end up doing the same exact physical exam that you would have done on a standardized patient. But conforming, I think, in a way, is taking that really in-depth physical exam and making it fit every patient scenario, and coming up with as much of that information as you can get by doing a really thorough exam. And then going back and saying, if I couldn't get these pieces of information right here, right now, maybe I can go back later when the patient is a little more awake or able to move around a little bit better, or is up and walking around with the nursing staff or PT or OT, and then make an attempt to fulfill the rest of my exam. And I think it works even like in rounds. You conform to the new way that this one preceptor likes to have a presentation done to them. It doesn't mean that you didn't look up all that information and have all that information ready to go for yourself and for the rest of your team when they have questions, but you make sure to focus in and be concise towards what you know your preceptor or your attending wants to hear. So I guess it's like melding together the good pieces of conformity and also just like completeness and really making sure that you're getting done what you want to get done. Would
you view that as a negative thing? Are there any negativity with conforming in medicine at this time?
I think so to some extent. Like if we're conforming just to conform because we want to get a good grade and that's all that we're caring about in this scenario is conforming to make sure that our attending is happy so that we get a good eval, then that does nothing for our education and it does nothing for our patient and it does nothing for helping us to really get a better understanding of why we're doing what we're doing in that situation. We're just conforming then to almost like look perfect in someone else's eyes. And realistically, we should be willing to, as we talked about a little bit earlier, fail often, because this is the chance that we have to fail and maybe not hit all the pieces of information that we needed to hit, because we have someone like you standing on the other side watching us and making sure that we're really doing our best for the patient.
Mm-hmm. Denzel?
Yeah, so and there's so much to unpack with this topic and it's very difficult where to start, but I just reflecting on my own experiences, you know, as a third year, you come into clerkship so impressionable and you are, you know, keeping an open mind and you don't want to make any mistakes and you're scared of, you know, disturbing someone or doing something the wrong way or anything. So you're just copying a lot of what you see other people doing. And that's what I think a lot of the conforming is happening. And oftentimes there's positive conforming and there's also negative conforming. And I remember in my, you know, in the beginning of my rotations, you know, you would see people go into like a contact precaution room without any PPE or anything like that. And the team goes in like that. And you don't want to be the person to stick out who's like taking the time, or they're going to go talk with the patients. You want to miss out on what conversation is going on. You don't want to take the time to do that. So that was kind of me early on in my rotation, just kind of being fearful of what's going on. I think what's wonderful is having mentors who are who push you for excellence and demand better from you. And so I'm so thankful for the sim team who teaches us there's no shortcuts. You know, like the shortcuts that you take are just going to hurt your patients. And so, you know, Cheryl and Heather and everyone and Dr. Stolin have just been pounding this into us that you can't copy bad habits. And that's the thing that worries me about negative conformity, is that eventually it will turn into bad habits. And that's why when we're doing these sims and they're watching us and they're asking why we do it this way, it's because we're slowly developing these habits. And at a stage where we're so impressionable and these are going to be our lifelong habits, I think it's important that mentors and other professionals who are above us can stop us and really make sure that we correct this as early as possible, because I think it's important to fix this as soon as possible. So I think another problem inherent with conformity in medicine is, as a medical student, it feels like a power dynamic. There's a big power dynamic aspect to this where, you know, you don't want to, you know, as a medical student, it's almost fearful to speak up or to do something. So you just copy things. Mm-hmm. I think some of the best mentors I've had have openly asked us to challenge them or to criticize them, or asking the residents who are asking us to kind of, you know, if you see me doing something, ask me why I'm doing it, and just kind of creating, at the end of the day, a safe space where you just feel comfortable asking the question. And I think that's something that's difficult in medicine because of the time constraints and the pressure that's existing in the field, and you feel like there's no time or the space doesn't feel safe. But I think it's important for to have this kind of collaborative atmosphere where you can challenge individuals.
You articulated this excellently. I think I really liked a couple of things that you mentioned there, is that as a medical student, you know, culture of medicine does have a little bit of a hierarchy, and it's an unspoken sort of power game at times. And I can imagine as a medical student, if you see something that is unethical or not done the way you have been taught, most of you will be hesitant to question your team leader. And so my question then is, how do you process, Denzel, I'll start with you. How do you process that conflict, that moral dilemma? So you learn something in the classroom as an M1, M2. Now you are fresh and impressionable, as you mentioned, in M3, and you see some bad behaviors, or you see some behaviors that are new to you, that you know are not acceptable. How do you resolve that conflict? Do you have a place that you feel like you get that conflict resolved? Or is that something that you just kind of take care of it by yourself? Like, tell me your process.
Yeah, so I think initially when I was early on third year, I would kind of keep things to myself, and it was a true moral dilemma, because you're just struggling and you don't know who to talk to. As you kind of work with, throughout the years, you just learn and grow and mature. I've learned that the best way that I can deal with it is just to find someone who I feel very comfortable to talk with about the situation. Hopefully someone in my team. Generally, it's just the next person above me. So the intern would be someone I feel very comfortable, because they understand where I'm coming from, and they weren't in my shoes not too long ago. And so oftentimes as a senior resident, it's very open and very understanding, but generally it's like an intern or second year resident, and just kind of speaking with them my mind and letting them know what I think is going on. Sometimes they'll agree with me, and we'll just, especially if it's something with an attending, they'll agree with me, and we'll just kind of, at that point, it's like, do we bring up with the senior resident, or do we just keep it amongst ourselves and hope this doesn't happen again? But I think one of the biggest things is just finding someone else you can talk with, someone who's part of the team and understands the situation, and then from there kind of discussing ways that you can bring it up and resolve this issue so it doesn't happen again, especially if patient care is in jeopardy or in harm at any ways. I think it's important to make sure this issue doesn't get lost and you just discuss it and then forget about it, but to make sure there's some sort of resolution that occurs.
Great answer. Matthew?
Yeah, I agree with Denzel. It's one of those times where it's kind of nice to have the interns on your team with you, because they're just slightly removed from medical school, so they still understand how it felt to be in your shoes, and so you can have that conversation with them, and they're really, really great about like expressing what it's like from their side of things, now being just clinically practicing rather than also having the academic practice as well. So it's kind of nice to have them as your bridge in between the team, if that makes sense.
Now, I have had the privilege of working with Cheryl and Heather for over 5 years. We have worked at the CIM on Capstone, so I know their style. And I can tell you with full confidence that one of the reasons our students have some resolution or some of these questions answered is because they are practicing the CIM Center with great integrity. They often have these conversations with students about what is the right thing to do and why is it important to stick to what is right versus what you are observing on the wards or in the clinic. So Cheryl, would you like to focus a little bit on how are you having these conversations with students? Because I know students are very comfortable with you and Heather. They do come and talk to you about these very difficult conversations that they may have a hard time talking to clerkship directors or even their attending physicians that they feel comfortable with. So can you tell us a little bit about that?
So we have, the pre-brief, we do the SIM, and then a major part of the process for simulation is the debrief, where we create a safe space. And throughout the SIM, we consider psychological safety as a foundation to this. We have to create an environment where students, whomever, staff come in and they can have a moment. They can make it, for lack of a better word, make a mistake or not get things done right. So in the debrief, we sit and we observe. We say, I noticed that you did this. Tell me about it. Tell me why you did this, or tell me how you came to that decision. So we're not judgmental. The question in of itself, the way we go about asking the question, is just an observation. Foundational to simulation is we're watching and we're observing, and we can only speak to what we see. We don't know what you're thinking. We don't know what your reasons are. So we have to ask, I noticed that you did this, tell me. And the answer sometimes is what you think it is, and oftentimes it may not be what you think it is. So I think, and then we just have a conversation, you know, what do you think would be a better way to handle this?
And in those questions that we ask, that's where we find out about the conformity. So when we ask them, tell us, you know, we noticed it, tell us about that. Well, this is the way that I see the resident doing it. Or this is the way my attending does it, or this is what I saw. So that's where the conversations come for Cheryl and I, because that's when Denzel or Matt might say, oh, this is what we saw. And so then we began to have the conversation about, okay, but what do you think? What, you know, what is it you think about it? And we say, what kind of doctor do you want to be? Do you want to be the kind of doctor that you're watching, or do you want to be different from that? And so we kind of give them that space to start to think about what they want to be, right? That it's okay to do it the way that you've been taught. And then we try to give them some language for if they get called by the resident or called by somebody for why are you doing that? You know, we already told you didn't. We try to give them some language to go back to those people and say, like for Denzel, to, you know, I mean, I had a heart attack when I heard that people are going into contact precaution rooms without precautions on. I'm like, oh my gosh, is that really happening? So what is the language we can give Denzel and Matt to say that yes, they are going to put on their PPE because it's necessary. So I think, and Cheryl's the one that came to me about this during STEM because she was debriefing someone who got very upset with her feedback. And because she was doing what she was seeing, and she was very upset because, you know, med students don't want to be wrong and they don't want to get in trouble. And I think she felt like we were getting her in trouble when we weren't, but she was very adamant that this is what she'd seen. And so Cheryl heard that several times during the STEM. Go ahead, Cheryl.
Yeah, it is the conflict between education and practice that we know it's there, but no one addresses. And then we send these students out to kind of go out there, figure it out, you know, and somehow at the end of it all, be competent, safe practitioners. When we know the problem exists or the issue exists, it's depending on how are we going to bridge the gap between education and practice. And I heard Denzel speak to time. He absolutely, you're in clinic, you're with your attending or with your team, and you have a list of people, of patients that you have to care for. So to take the time to teach the student why you can do things a certain way and maybe they shouldn't at the initial part of their career, that's a part of, you know, having the conversation, explaining why I'm doing things the way I'm doing them. So I think to sort of send the students out without an opportunity or a place to go where they can. Denzel has found, you know, the intern but not everyone has that. And so how do we shouldn't just send the students out and figure out how to navigate this. We have the opportunity and we have the tools and we have the resources to create something or to augment something that we currently have so that they understand what they're going to see and what will, you know, what they need to do in their as they're learning.
So while we're discussing this language, I wonder if Matt and Denzel, I know we're going to get to some questions at the end, but a question has already come up. What is that language that you have learned? What kind of language can you use with a superior? And thinking about all health sciences learners, so not even just med students, but what can learners say? What does that language actually look like? Do you have some, Matt and Denzel, some language that you might be able to share with us that you've learned?
I think for me, it's when I'm bringing something up to a superior, I try and come from a place of humility. Because it's like, for one thing, I don't know the full picture or what's going on or why they decided to do this or that. And so I try not to bring something up in a judgmental or accusatory tone in any way, shape or form. So I just try and like, hey, like, I just wanted to ask you a couple minutes to chat. I noticed this was happening this way, X, Y, and Z. And I've previously been taught this way, X, Y, and Z. And I was wondering if you kind of like share why you did it this way or what's going through your head or your thought process, because then it comes from a place of learning, and they have the opportunity to teach you, which I think is better than them trying to defend themselves of like why they did it if they feel they're being attacked or something they're the way they were taught is being under judgment or something like that. That's at least my approach.
Yeah, I definitely agree with Denzel on that. And then like coming to the PPE type of thing, it's just if you just put on your PPE when you're going into the room instead of just walking in with the team, it seems to like get everyone's attention, and then they notice that this is what they're supposed to be doing too. And maybe it's not going to change every team that you're on, but sometimes just like taking that extra second to stop and think about the fact that they're also supposed to be following the hospital policy will change their actions in the future as well.
I agree with that as well, because I remember like at this point, in the beginning you're scared and you want to conform, but there comes a point, especially with Cheryl and Heather telling you that there's no shortcuts in life. You learn I'm gonna be the one who upholds my values, and I'm not gonna compromise them. I'm gonna put the PPE on every single time, even if I'm a little bit behind. And you just kind of stick to that, and then you see the intern who's also following your lead as well, or the next person as well. And so I think it's just making sure you don't compromise on your values as well.
Jessica, does that answer your question?
I think it got right to the question for sure. And Sonal, do you have other things that you want to bring up? I already have a couple more questions that have come through, but you cover your material and then we can get to questions.
I think I have 2 questions for the whole panel, and then maybe we can move on to taking some questions. My question for the students now, again, is what is a good role model for you as a M3? Because I can tell you, based on my experience, that I was a medical student at one point. I did learn all the things that you did in my M1 and M2 and M3 and M4. And as I have evolved, I have changed my ways of practice of medicine. My physical exam skills have changed over time. My communication with students have changed based on what's worked, what's not worked. I have the privilege of being very close to the students in terms of academics and teaching. So I get to hear a lot of feedback, and the good and the bad. And I have taken some of the bad, not so good feedback as a constructive way of changing things in my own practice. And so, Matt, how would you define a good role model when you are in the wards, when you are in the, what is your definition of a good positive role model?
Yeah, very difficult question. I think it's something that we talked about actually the first time I met you, which was looking for someone who you wanted to model your life after. So not necessarily like someone who you think like this is the way that they practice medicine, that's the exact way that I want to practice medicine, but they live their lifestyle and they like being themselves, and that's what I want to be. Like I want to be able to have a good lifestyle and also be a great physician. And I think that you find those people that really show you what it's like to have that work-life balance, and then those become great role models for you. And then once you kind of have those role models in place that help you with your balance in your life, you can move on to finding some physicians out there that are really, really great at their physical exam skills, or are amazing surgeons, or are amazing at doing whatever procedure that they are doing. And then you learn from that too, and how they dedicate themselves to that. So it's kind of like picking the pieces of each role model that you find to make you into what you eventually want to be one day. And so that's what I'm kind of trying to do right now with the role models that I'm selecting. Yeah, I guess if that answers your question.
Yes, thank you. Denzel?
Yeah, so I think Cheryl says this multiple times where, they need to train us right so that we're able to take care of them in the future the correct way. And so, but it's honestly, it's true, because the way I look at a role model is how would I want to be treated as a patient? How would I want them to take care of me? Would I want them to not do, be very thorough or comprehensive, or how I'm being taken care of? And that's kind of my mentality now as I move forward, is how would I treat this person as if they're my mother or my sister? Because I want to give them that attention, that care. I don't want to take any shortcuts with them, and make sure that they're getting the proper care that they want. And the way I do that is just looking at everyone I've met, all the physicians and residents, and just kind of picking and choosing the good qualities I really like from them, how they interacted with this, or how they organize themselves in this way, or how they take care, like bring themselves up when they interact, when they walk into a room and stuff like that. And at the same time, also trying to avoid the bad qualities I see that I don't want to have in part of my practice. And so it's just kind of being very cognizant of everyone, because you can always learn something from everyone you meet. And so just being very aware of that.
Mhm. Great answers. And I think at this point, I want to shed a little bit of light from the attending standpoint and how things can get a little bit, change as you get into the business side of medicine. So as someone who enjoys teaching, as someone who has absolutely enjoyed teaching medical students, nursing students, I can tell you that evidence-based medicine or academic medicine is very different from the business aspect of medicine. And this is where things can get very blurry and things can get complicated for practicing clinical doctors, right? So for example, we have a ton of research that does show that attendings who actually teach residents or students or learners, when they have learners, that they traditionally tend to see fewer patients and hence are less productive than attendings who do not have learners. Now, from someone who always has had productivity in mind, because medicine does have, whether we like it or not, we do have a business side of medicine that often gets into our holistic and academic way. Somebody who is on a time restraint, so we get no more than 15 to 20 minutes to see a patient, and we have to see a certain number of patients per day. Teaching can take away some time. That doesn't necessarily equal compromising on basics and integrity of medicine. And so you can combine those two, but requires a lot of organization. I can tell you that I've become a more organized teacher in the last 2 years, as I have done this for over 10 years. Being organized, understanding your learner, understanding your learning environment, knowing what patients you could actually have for teaching purposes. I think those are all key pieces. So having a little bit more resources for our faculty on how to balance teaching and the business side of medicine. Also having leaders who are familiar with the business of medicine and academics, because academia has become very nebulous. You can call an institution academics, but what really happens under that umbrella is something that we all need to kind of investigate and look into. It's very easy to get a title, but what does that actually mean in clinical medicine? It's very different. Not all doctors are teachers, and not all doctors like teaching. So kind of teasing out who's your faculty who enjoys being a teacher, who's a faculty who enjoys the educational aspect of it, and then who's your faculty who actually enjoys productive and clinical medicine, but may not be as inclined towards teaching. And both those are fine. Those are both good domains, but recognizing and placing people in those domains is important. And so I think, being transparent, being open to the students. I'll give you an example of doing pulmonary exam in my practice. When I had students, maybe a couple of years ago, I would do pulmonary exam the way I do on most of my patients, which is on their fabric, on their t-shirts. And one of the primary reasons for that is I'm an outpatient doctor who has seen patients for longitudinally for years. And so I'm familiar with the baseline. I'm comfortable with lung sounds through a fabric. And when I'm not, I do, ask the patient to get in a gown and do it on bare skin. Now, this is a part that I never communicated with students until I started having conversations with students and Cheryl. So now when I do that, I make it very clear to the students that your ideal exam, especially when you are a new learner, especially when you are in the early stages of your career, should be on bare skin, because it takes time to learn normal breath sounds and but wheezing and added breath sounds, unless you have mastered breath sounds on bare skin. And so I communicate this to the learner as I'm going about my exam, and that gives them an idea of what is expected of them, why a seasoned physician might not do a cardiac exam or pulmonary exam on bare skin, and what are the reasons? So I feel like that authenticity, that clear communication is always a good idea. That way the students are aware of the evidence-based medicine as well as the ideal medicine. So Cheryl, do you have any comments on this? On what are some ways to bridge the idealistic medicine and the practical medicine, which is layered? It's not as simple as, when you are in M1 and M2. It's very different when you become a clinical practitioner.
Yeah, I think, somewhere in the curriculum, we have to have somewhere where we formally prepare the M2s for practice, where we are going to say, as you do, you will see these things in practice. And to be able to create space for them to ask without feeling. I think we've already, Denzel and Matthew said, not feeling that they can't ask questions, but I think we need to really formally create a space or something where we are going to have that conversation with them about the difference between academia and clinical practice. It's just, we expect them to figure it out themselves. And the big thing too, in that is the time constraint. And I hear both Denzel and Matthew and yourself speaking to the fact that you are given, you have students and you have to teach, but no one really plans or gives you the time to teach. So I think that's preparing the students to go into clinical practice, but also preparing the practitioners, the physicians, and whoever is going to teach to give them time to do that. So I think that's what I see. I just, our educational system is very interesting in that we expect outcomes, but we don't build in the necessary structures to create it and to have that outcome. We somehow magically expect it to happen, but we don't formally create it. And so some students will get it and some students won't. And that is not, if we know that's not what we should be doing right now. We should start thinking about how are we going to do that, to create space for the students to understand why clinical and academic is different, and how we're going to prepare them to navigate that.
I like what you said, Cheryl, and this is a question and also some information for Denzel and Matthew. One of the reasons that I have liked education and I have been part of education is selfishly, I know that you are the next generation doctors. You are taking care of all of us here. So we want you to be well-trained. We want you to have integrity, and we want you to practice good medicine. So that is, and the way you do that is by role modeling. Number 2, staying close to what's changing in medicine. And number 3, being the change that you expect others to have. I'm a firm believer that medicine for the longest time was handled by people who did not know medicine as well. And so we need leaders like our students to be at the table discussing policies, discussing changes in medicine, discussing what is working, what is not. And unless we have people who are doing medicine and are aware of it and would like to be part of problem solving, this is not going to change. The balance of academia and business and where we are has to change. And the only way it will change is if our students who are going to be the future doctors are involved in this change, are aware of the actual challenges of clinical medicine. So Denzel, what would be some of your ideas for this clinical dilemma or moral dilemma?
I think it's a very difficult issue. I think for me, some of the solutions could be to kind of what you said is, I think as a newer physician or someone who's younger in their practice, I think it's important to be as thorough and as comprehensive as possible. Kind of what you're saying, how, these younger people need to actually put the stethoscope onto the bare skin versus like a more seasoned physician kind of understands more of the differences and nuances of listening to heart sounds and breath sounds. I think it's important that as when you're new in training, just to keep reading, to keep having these discussions and to keep reflecting. so that we can have these conversations about conformity, because then you become aware of it. And then when you're out in practice, you can see it and recognize it. And then you can tell some of your other peers and coworkers about what you're learning. So I think the biggest thing is just to keep an open mind, stay humble, and just to keep learning and having these conversations and reflecting.
Thank you, Matthew.
Yeah, I like some of the points that you brought up about policies and business and how that impacts education. And I think it's important that as students, as we're going through our education, that we learn more about that business aspect and maybe apply ourselves a bit to part of that business aspect, whether that means in our further careers, like advocating for the physicians and the healthcare workers at our facility, or becoming one of the business leaders of a facility or of an institution or something, to try and help balance that needing to be efficacious and get our work done, but also needing to learn and change and really take good care of all of our patients and our students at the same time. So I think that that's something that we as students can look forward to, and maybe at this like learning stage, start preparing ourselves to be able to have those conversations and be a part of that sort of institutional leadership.
I agree with both of you. And I think this is my favorite line that my dad is to say to us: if you're not at the table, you're on the table. So you pick your position. Do you want to be at the table solving the problem, or do you want to be on the table to be solved by other people, right? And I choose to be at the table because I think we all need to weigh in. We all need to have a safe environment, including our faculty. Our faculty should have a safe place to talk about some of the restraints and reasons why they aren't able to provide what they would like to. If you talk to majority of the faculty, they will actually say that they would like to spend time with the students teaching. However, they don't have that time to do so. And so I think safe environment for students, safe environment for faculty, resources for faculty and students to address some of these issues. Introducing students to clinical medicine early on, whether it's SIM, whether it's getting them in the wards and in the clinics early on, having those open conversations about evolution of medicine as you progress, how your practice of medicine changes and why it's very critical for us to have these dialogues. Cheryl?
Yeah, I think, the leadership piece, that's where it starts, like from the top down. And I think you have the leadership and you have the students, and the students have an equal voice, I think, in if their experience is not what they expect, I think that direct connection to leadership should happen, because that's what we're here for. This hierarchy in this organization isn't created just to be created. It's here for students. And if they're not getting what they need, then I think that feedback, again, should be direct. It shouldn't be the multiple layers in having to get through those layers for leadership to understand that the students are not getting what they need. We have the resources. I do believe we have the resources. We just need to allocate them a little different and think of time a little differently. But I think it starts with leadership and students having that dialogue as to what they're experiencing and what their needs are. And so as they go through, they are, we're creating safe practitioners. I mean, that's foundationally, again, I keep going back to safe practitioners, safe patient care. And if we're able to do that. So, did you have something?
Yeah.
Dr. Solin is here also.
Sorry.
Can
Hi,
you see?
Dr. Harder.
Oh, hi, how are you?
Panel. I was so excited to hear it, and Cheryl just kindly invited me because I was finishing up the SIM. I don't want to steal the show or anything, but I was thinking about this because literally at the last capstone that we did together,
Yes.
some of the students came up to me afterwards and said, "Hey, Dr. Solon, one of the things that we're sort of learning in the SIM Center here in these capstones about sort of the ideal is like, how am I going to do that working in the ER pit next year as an intern, where I know what those workflows look like?" And I really didn't have a great answer for them at that time. I had to kind of chew on that for a little bit. And when you think about what causes burnout for students, residents, and practitioners, it's really the disconnect that, right, the reasons you came to medicine are not facilitated by your workflow in the hospital, right? The connection to patients, the sense that you're really giving them the time that the quality that is required. So there's a sort of moral disconnect before the ideals that you've learned and what you get to apply within the confines of the system. And I find that just the expectation that the system will not provide you with that opportunity intentionally. It may happen occasionally by accident, but by and large, it may not, it's not designed to provide you with that opportunity. You sort of have to refill your tank. And what I realize is that that's not something that the students necessarily see, because they happen kind of in the nooks and crannies around our day, right? The most enlightening conversations and the biggest connections I form with my patients as a trauma surgeon taking 24-hour call is after that call, right? I'm rounding hour 30, and then I give them unlimited time because I'm not holding a pager anymore. I can just sit down, there's no spectrum of traumas going off. And I have very long conversations with my patients and their families the next day. Whereas the residents and students model on that behavior, well, they're asleep, right? They went home, they got sent home due to duty hours. So I feel like on some level you miss some of that positive quality that you could model on, but it's not in the immediate snapshot when you're kind of on the rotation, just seeing some busy, stressed out trauma surgeon running around trying to put out fires. So I think it's important to recognize that you have to build that time somewhere in your day or outside of your day to rejuvenate yourself based on those patient connections that you find valuable. The reason I stay when I've been up for 30 hours isn't because of a sense of duty. I actually am emotionally and spiritually rejuvenated because that's when I connect with my patients, right? And I don't have the time to do that necessarily on call. So you have to find that time within, whatever specialty you're going into, but it is possible. And I'm not sure it's something that the students necessarily see, intentionally.
And I think you say it so well, Dr. Solon, but one of the things that I feel as a faculty is that moral dilemma does not end in medical school. Moral dilemma is something that we deal with even as a faculty on a day-to-day basis, because the idealistic medicine and the practice of medicine, which is the business side, are completely two different skill sets. And to merge that and to still stay integral, like to stay, with your value system and to practice medicine for the reason you signed up is very, very critical. And I think I'm going to give it to Jessica, because I think you probably have some questions and we have last 10 minutes left to do that.
Well, first of all, thank you so much to all of you for sharing your clinical frustration, the move from classroom to clinic frustration, but also how you've been able to create that psychologically safe space. And I feel like everything that you've shared is so transferable to all the health sciences, which is really helpful. Now, one of the questions that has already come through has already been answered in some of the things that you've talked about. So I'm going to go on to the next one, and it's going to dive a little deeper into this moral dilemma that you've been talking about. So this one says, in the first and second year of medical school, Creighton focuses a lot on the humanities, so their gold track. And I know a lot of the other health sciences, they also have a gold track, so it'd be very similar. But they focus on humanities and cultivating things like compassion, empathy, and holistic care for patients. So can you speak to what you see happen to students, or the students speaking to what has happened with them as they transition into the clinical years? Do they see these same human qualities modeled by their residents, their attendings, and the hospital staff?
Students, do you want to go for it?
Sure. So I think for me, Creighton being a Jesuit institution, reflection is like one of our core values, and it was done very frequently in our first and second years. And I remember at the time thinking, man, I just need to get back to studying some of my other classes. So it was kind of frustrating to have to do some of these reflection exercises. But after each reflection exercise, I would come out feeling so refreshed, and so I'd had this new take on life and new ways of how I would want to be in my future practice and new ways of how I want to take care of people. And I think it's important that we have these values instilled at us in the first and second years and have these conversations, because I think it's so important in how we shape our practice, rather than there's so much more to medicine than just the sciences. It's really taking care of the patients and their souls and their spirituality and who they are, and understanding that and being kind to them. I think for me, I have seen a lot of that in the people I work with and the residents and in the attendings, and you see so much compassion and so much kindness. And part of it's because it's the career that they picked and they want to be there to serve people. And some of it, I think, it's just who they are, and that's why they're in this field. But I think it's, it's been remarkable to see that, and it really inspires you in medicine when you're feeling a little jaded or you're feeling a little burnt out, and you see someone with so much passion and so much caring for people that you want to copy that and adopt it yourself.
Mm-hmm. Matt?
Yeah, I agree with Denzel. And I also would like to add in that I think that the gold track and all of those different Jesuit values that are really taught throughout the first 2 years of medical school come in super handy when you become a clinical portion, because every single patient that you have has some sort of social aspect that needs attention as much as their physical ailments. And so whether that's working at ValueWise, where you have a lot of patients that are lower socioeconomic status or homeless or underinsured, and being able to provide them with the correct resources out there in our community, Creighton helps us to learn about those resources, which is nice to have, and definitely teaches their residents and their residency programs about finding those resources for their patients too. So it's nice to see that continue on throughout your clinical years as well as you work with each individual patient.
Jessica, if I may add to that, I always tell my students, when you are going through M3 and M4 year, besides medicine, you also need to observe good role models, good behaviors, and not so good behaviors. And then you get to pick and say, who do I want to be? Like, what kind of doctor do I want to be, and what kind of medicine do I want to practice? That is actually a big part of clinical experience as an M3 and M4 student, because medicine will come. They have a lot of resources on their phone, on their apps to read up on criteria. What is not taught is how to be a idealistic medicine in terms of patient care and our purpose in medicine. That sometimes gets lost in the business of medicine. And to keep that intact and to keep that going for decade after decade can be a challenge to the best of best. And so students need to observe good role model doctors, sit down with them, find out what are they doing to keep that purpose and joy in medicine, and actually practice that. I say that quite often. I hope Matt and Denzel remember me saying it.
I think for this organization and for this institution to have survived as long as it has, both Creighton and Dignity Health St. Joe's, I think we have had to display those core values of empathy and caring and kindness to our patients. I think no one gets up in the morning, puts on their clothes, gets in their car and comes to this organization without that as their core intent. I think along the way, there may be some challenges that will derail you for a moment, but I think we all come back to the understanding of why we are doing what we're doing and why we are here. And I think if nothing more than that, the last 2 years has really put that in, spotlighted the fact that as caregivers, as healthcare teams, as providers, that we are dedicated foundationally to caring for you, being empathetic and being kind and understanding to our community and the people that we serve. Ourselves, we are the people that we serve.
Jessica, do you have any other questions?
I think that answered the question great. And all the questions that were submitted to me, you've already touched on along the way. So I don't think it makes sense to read any more of those. But we still have just a couple minutes left. So if there's any other questions, you can put those in right now. Mm-hmm. But you covered a lot of material, and you covered a very global look at the health sciences learners and how they're making that transition and how we can help them bridge that sometimes the gap that they feel between the classroom and the clinic. So a lot of great ideas that are tangible for faculty to be able to take back, and a lot of great language that we can use either as learners or as faculty.
I have one closing quote. This is a quote that I actually live by, and I feel like it keeps me going even on days that are tough. And it goes like this. It's by Steve Jobs, And it says, those of us that are crazy enough to think we can change the world, we are the only ones that stand a chance. So here's what I say about medicine in general. We often hear about, you know, how difficult it is and the burnout rates, they're always in a phase. And I know that as a physician and as a nurse and as anybody in medical profession, this is a calling. This is not just a job. This is a calling, right? And unless we are there for all sorts of changes, not just patient care, but healthcare policy changes, what impacts our day-to-day life, unless we are involved, it is not going to change. It's a Titanic, it's Mount Everest. It's not going to change with one workshop or one module. It is a combined effort of everybody that, you know, is involved in taking care of patients. So I think communicate, reach out, find out about resources, be at the table. I think that those are very important steps for anything that we will tackle.
That's a great quote to end on. And I just want to thank all of our panelists one more time. Thank you so much for your willingness to share your time and to share your knowledge and the things that you've learned. So we appreciate it, and everyone take care. Thank you.